So I'm John Prpich. I think we had some issues online with some of the introductions. I guess Zan sort of did an introduction, but I think most people sort of know me. I'm a pediatric pulmonologist down in Tampa, Florida. And so this morning I'm talking about asthma across the lifespan, right? So this is sort of our overall arching theme for the meeting. And so kind of setting off, I wanted to just kind of frame some cases in your mind as we talk about the different types of asthma, as we think about how asthma changes across, at least in childhood. So the first is just sort of a kind of a vignette. So we have a 3-month-old male recently admitted for RSV to the Children's Hospital with cough, increased work of breathing, hypoxemia, and reported wheezing, but really no other medical problems, right? There's a negative family history. There's no family history of asthma. There's no family history of allergies. The child doesn't have any eczema, really just this wheezing episode. The second sort of vignette is a 14-month-old male who's been to the urgent care 3 times in the past year, coughed and has labored breathing when sick, has been given oral steroids multiple times, and albuterol seems to help them. And both mom and maternal grandmother have asthma and also eczema. The third sort of vignette is an 8-year-old female with eczema since infancy. She's got allergic rhinitis. She has recurrent cough. She coughs a lot with weather changes and during spring. And she also coughs when she's trying to run during PE. She takes Zyrtec during the spring and summer, and albuterol helps her. And she's been prescribed Flovent, but mom's worried about chronic medicine, so they're not the most compliant. And then the fourth little vignette is a 16-year-old female who's highly competitive volleyball player. Well, college scouts are already showing up at the games to kind of scout her out. And she's reported new onset of difficulty breathing when she gets out on the court. Her friends kind of look at her funny because they can hear the wheezing when they're not even sitting or kind of standing next to her. And if she sits down and really kind of focuses and takes some slow breathing, she starts to feel better, right? So different kind of vignettes. And the question sort of in your mind is this asthma? Are all of those patients asthma? And so we're going to talk a little bit about history and epidemiology. I think Dr. Lucas, which first off, I think we need to give her a round of applause for seamlessly going through those technical difficulties. I know that I could not have done such a good, she came prepared with her printed out slides, which I think we're all going to learn as presenters to do next time, right? So we're going to talk a little bit about history and epidemiology. She went over a lot of that as well, so I'll try not to sort of dwell on it too much. We're going to talk a little bit about preschool and viral associated wheezing. We're going to talk about asthma phenotypes. We're going to talk about asthma endotypes and how those may change kind of over childhood. And then we're going to touch a little bit, which Dr. Lucas touched a little bit on as well, some of the other factors that may play a role in asthma development. And then we'll talk a little bit at the end about things that can mimic asthma as you're seeing patients, right? And so this is some of the epidemiology, right? Asthma, most common, chronic disease of childhood, right? We already said 1 in 12 kids. So asthma is very common. And we see this shift over time with sort of the prevalence of male, female, right? So in clinic, the younger kids with more severe asthma tend to be more male, right, in the blue. And then as we get older and as we talk about adult asthma, you'll see more of those severe asthmatics female. And so we see this gender shift as we move through severe asthma. And then, this really was eye-opening, and I knew, but the amount of money that's behind the treatment of asthma, right, is billions and billions of dollars, especially as we move into some of these new treatments, but realizing that, there is a lot of money behind asthma treatment. And so I think the sort of history of asthma is sort of interesting. I don't know. I think I heard online things are a little bit blurry, but really, and actually it's kind of small on here, but really even back in the Greek, so you can see up there the Greek word for asthma, right? First used by Homer in the Iliad. So it goes really far back, right? Short of breath, short drawn breath, hard breathing, right? 800 BC. We move into Hippocrates. Really was the first really to treat it as a real disease, not just a spiritual disease, but still thinking about this imbalance of the 4 humors, right? So we're not quite on mark yet. But then we start to get in the 1600s and we start to disagree. It's not really the 4 humors. We start to think that there's something more involving maybe the pipes, narrowing of the pipes. And then 1678, Thomas Wills first to describe asthma as something other than disease of the spirits, right? Obstruction of the bronchi, thick humors, swelling of their walls, and obstruction. Really, we've had treatments that are sort of, starting to get in the realm of inhaling things, right? Dr. Heitzelter in the latter part of the 19th century, defined asthma as a paroxysmal dyspnea of peculiar character with intervals of healthy respiration in between attacks. So we're starting to get into this idea that it's intermittent in nature, right? And so Francis Rackman was a physician in Boston, and he sort of set the bar pretty high. He graduated Harvard at the age of 14. Made me feel like a slacker. and really would go on to be one of the greatest asthma and allergy experts of the 20th century. And he was one of the first to really start, believing that asthma is more than just, a disease, and that there could be allergies involved, right? And so his paper in 1918, categorizing some of the first vocabulary with this idea of intrinsic asthma, extrinsic asthma, and different factors sort of weighing in. And that'll kind of play in when I sort of read a paragraph from one of his papers, right? So asthma is a clinical syndrome, right? It's recurrent, reversible airway obstruction. And the key words there are recurrent, right? So when you're seeing a kid in clinic and it's the first episode of wheeze, it's their first episode of symptoms, it's a little bit hard to tell. I mean, you look for risk factors, but you need a pattern of symptoms and it needs to be reversible, right? So medicines help, your bronchodilators help, steroids help, and it's marked by these three hallmarks that we all know very well: airway inflammation, increased mucus production, and airway hyperreactivity. And there's a trigger, right? So here's some pictures, some histology. You can see normal over there to your left, and then an abnormal airway over to the right. And you can see the thickening. You can see the smooth muscle hyperplasia. You can see all the hallmarks that we see in asthma, right? And like I said, most common chronic non-communicable disease, especially in childhood. But the biggest key is that it's reversible, and that it's preventable, right? So most of the morbidity and the mortality associated with asthma is preventable, and it's heartbreaking anytime we see an asthma death. We just had one about a week ago over at St. Joe's, and it's really is heartbreaking. So some more pictures just so that you kind of get a sense, right? So normal is up top, and then abnormal is down below. So you start to see that smooth muscle hypertrophy. You start to see the sort of derangement of the epithelial surface. You get increased mucus production, epithelial detachment, smooth muscle hypertrophy, and inflammation, right? Inflammation. As we talk about treatments, then we think about the things we have, things like that air super out there. Inflammation is so key. Even in our mild intermittent asthma, we're starting to realize now that even in those patients that we've been underappreciating inflammation and mucus, increased mucus production. You can see all those goblet cells. Oh, wait, yeah, over here. No. Laser is not working. So, but you can see that sort of mucus, thickening, and then all the kind of goblet cell hyperplasia at that top surface, right? And so, like I said, though, as we think about, especially in kids, asthma is heterogeneous. It's not one thing. It was fun finding these pictures of these weird animals that, all these different pieces together. And so this is that quote. It said, "Surely it is hard to believe that the wheeze that comes to the young schoolgirl for a day or two in the ragweed season is the same disease is that which develops suddenly in the tired businessman or in the harassed housewife and pushes them down to the depths of depletion and despair. The problem is still wide open. The approach is not all clear." And that was Dr. Francis Rackman. So even back then, realizing that it's not one thing, right? It's a heterogeneous syndrome, really, of findings, right? Constellation of symptoms and signs rather than just a single diagnosis. It encompasses different pathophysiologic mechanisms, and a better understanding of these mechanisms will result in a more precise definition of asthma and a better characteristic of specific risk factors and a more accurate identification of individuals with poor prognosis, and set the ground for a more personalized therapeutic approach, which is the key, right? Personalized medicine. And so I think, we already heard sort of, from Gina, right? A heterogeneous disease usually characterized by chronic airway inflammation, history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity, together with variable expiratory airflow limitations. So once again, recurrent, variable, but reversible. And so this is what, as a pediatric pulmonologist, I feel like we're constantly always saying, right? Children are not little adults, right? Although asthma is the most common chronic pediatric lung disease, the diagnosis is still based on our clinical exam and parental report, especially in our younger patients where we're not really able to get reliable spirometry. We're not able to get reliable kind of measures of airway flow or airflow or airway function like we can with things like iOS. And so sometimes people will describe peds and taking care of kids as veterinary medicine. And so this is, even just spending some time talking about what do we mean by wheeze, we take that for granted. And when I talk to the peds residents and when I do education, it's really easy to just ask the mom if they've heard wheezing, or if people, has there been physicians that have heard wheezing? And I'll be honest, even as I'm talking to families, I want to know, well, what was it, an ER physician? Was it a primary care physician? Was it your next door neighbor? Did they, who is it? Because wheezing is not one person's wheeze is another person's rhonchi sometimes, is another person's, the physical assessment of wheeze is not as easy as it sounds, right? So continuous high-pitched sound, musical quality. One of the things I try to get home with the residents is that it's this what we call polyphonic. Asthma affects the lung differently in different areas. And so as they breathe with every respiratory cycle, it's going to sound different. And that really matters when we start talking about viral associated wheezing and bronchiolitis, because it's a different physical exam. You know, it's one of the many kinds of noisy breathing in preschool children, right? There's lots of reasons for kids to make noise. And so the parents they're gonna have a wildly, what they call wheezing can be very different. I've had families that will constantly, they'll just say wheeze, wheeze, wheeze when I'm talking to them. And then when you really kind of dig down, what they mean is nasal congestion, or what they mean is that they see work of breathing. I mean, so what, sometimes it's really important to have them try to define to you, like, well, what do you mean when you say wheeze? What, can you imitate it? Or can you, just trying to get a sense of things? Because sometimes what you think they're, mean by wheeze is not what the parents mean by wheezing, and so if based on parental report alone, children may be labeled as having wheezing when they don't, right? And wheezing should be confirmed ideally by a health professional. So we're constantly also trying to get a sense, have other doctors heard, have they heard wheezing in the emergency room setting? Have they heard wheezing, outside of the home, but hopefully by a physician, right? So regardless of the underlying mechanism, there's lots of reasons, right? So we can have asthma, but we can have anatomical abnormalities. We can have chronic infection, like in our patients with cystic fibrosis. We can have airway problems like malacia. And so over here, there's kind of a list of some of the other sort of variety of reasons. There's a pretty long list that you can have noisy breathing. Really, noisy breathing, wheezing just means there's some turbulent airflow and it's occurring somewhere in this complex respiratory tree. So is that turbulent airflow happening up here? Is the turbulent airflow happening down here? Or is it happening down here, which is where we usually think about in asthma? But is it related to bronchospasm, airway inflammation, mucus production, or is it happening because we have bronchomalacia, we have tracheomalacia, we've got a hemangioma that's getting in the airway, we've got neurofibromatosis that's pushing on an airway. So there's lots of reasons to be noisy. I think it's always important, but especially when we're talking about making that diagnosis in pediatrics, it matters, right? And so as we start to talk about what asthma looks like, I think one of the other concepts is asthma phenotypes versus endotypes. We throw that word around, but what we mean by phenotype is observable characteristics of an individual. So this is sort of that clinical description that we all think about, right? So, kind of, and there's gobs of them. There's lots of different ways to characterize patients by phenotype, and I'm going to kind of show some of those. And then endotype, though, is the underlying mechanism. What's happening, sometimes I say, under the hood that results in those phenotypes. And as we've started to have more, kind of increasingly more sophisticated ways to treat asthma, the endotype, what mechanism we think, what's happening under the hood, becomes more and more important, right? And so these are just some examples, just a few examples of some phenotypes, right? We've got, allergic asthma, you got obesity-related asthma, exercise-induced asthma, we got adult onset asthma. There are really more of those things. Like if you were to stand back and describe the patient, that's the phenotype versus the endotype, which Dr. Lucas kind of alluded on. This is that really complicated. Sometimes when I'm talking to families, I use the analogy of a relay race, and so anywhere, whether it's our airway, whether it's the skin, whether it's the GI tract, whether it's the nose, our body is in contact with the environment and we're in contact with triggers, whether those triggers are allergic, whether those triggers are irritants, whether it's pollutants, whether it's virus, our body is constantly sensing that environment and it sets off this relay race and it hands off these batons from cell to cell to cell, and it results in different kind of types of inflammation and types of pathology. And some of our, amazing new treatments take out the baton from some of those relay races. And our trick is trying to figure out which relay race is the most important. What baton do we want to take out of the race in our more significant asthmatics? And so because of that, this idea that asthma, like I said, heterogeneous is a big umbrella. And so underneath that umbrella, right, we've got lots of different ways that we think about it. Viral triggered wheeze, allergy triggered wheeze. These are all examples of that phenotype kind of a concept, right? High risk asthma, nocturnal asthma, early onset wheeze, all different sort of ways to describe this, what we kind of see. And we know this clinically, and this was sort of even back to that sort of paragraph that Dr. Rackman said so long ago, right? That these things change over time. There's so much variability, right? And so asthma, we have a lot of kids that will have, and most of our asthmatics, at least many of them, are going to have their symptoms in childhood, right? So at least one of their episodes are going to happen, but it may be very transient. It may not be associated with allergy. It may be persistent. All these different descriptions are even adolescent. And you can see the sort of time, and there's lots of graphs like this that you can find in the literature. how these sort of incidents change over time, and I'll show a few more. But there's still these black boxes, right? So as we talk about origins of asthma, that early in life, that 0 to sort of 3 months, 0 to 3 years, that transient wheeze, what happens there, and what are the origins of that, and how is that different than that same child, that same overlap, who's got persistent wheezing, and that same child who's got non-atopic or seasonal asthma, and there's still these overlaps, and they're going to look the same or look potentially the same in clinic, but how do you tell them apart? And then another sort of block right around 18 where there's just, it says black box, because how, like what happens, how do these people distinguish themselves is still not clear, right? And so, I think one of the more kind of common vernacular you'll hear kind of batted around are these ideas of, of course, never wheezing, early onset, sort of, childhood wheezing, later onset wheezing, early onset, sort of preschool wheezing, all these things. And you can see how these different phenotypes change over time. I think, probably one of the more famous sort of looks at these patterns really was Dr. Martinez over in Tucson, right? Almost now 30 years ago, looking at early life wheeze phenotypes, and did really some cool stuff where he did like lung function testing on infants even before. He just took a block of kids and they did infant lung function testing. And really was, I think, one of the first to give us insight that maybe there's a block of kids that are born with reduced lung function in terms of airway diameter and airway size, even before, there was any kind of environmental exposure, whether or not there was maternal kind of, pre-existing impact on airway development is always a question. But just this idea that there's, that there's these patterns over time, right? The kids that never wheeze, really the largest, that, sort of the control group, if you will, but then those early transient wheezers, persistent wheezers, late onset wheezers, all these kids that sort of change over time. And what makes it more complicated is they shift and they change, right? So sometimes these graphs make it look like the child is on one spot and that's their trajectory and they're not going to change. And unfortunately, as we look at like larger cluster analyses, we realize that they don't. They shift between. So it's not this clear-cut pattern that makes it very easy sometimes to tell the moms what we think is going to happen. And so those are based on sort of clinical characteristics. When they start to look at like lung lavage and other measurable kind of biomarkers, that you're able to break down some of these sort of preschool wheezers into other categories that give us maybe a window in terms of mechanism, right? So when they look at lavage, there's a block of kids where it seems like they're wheezing and they're noisy breathing and their respiratory difficulties related to reflux and microaspiration. These kids don't have a lot of allergy, a lot of atopy. You can find things like lipid-laden macrophages when you look at their bronchoalveolar lavage. And then there's kids that are more structural, right? So these are the kids I was alluding to, where if you do infant lung function testing, if you're able to assess airway sort of diameter and size, these kids seem to have structural abnormalities. Maybe there's some tracheomalacia, maybe there's some bronchomalacia, but they're, once again, not allergically sensitized. They don't have abnormalities when you look at their lavage fluid. And then there's a block of kids that are wheezy and they're noisy and having problems because of infection. Once again, not really sensitized, but you find things on culture. They often will have a lot of neutrophils on the cytology when you look at the cells that are in the lavage, and often you'll find cultures of Moraxella catarrhalis or other bacteria. And then kind of another smaller group that, really don't have clear pattern, right? This non-atopic sort of mystery group there, and kind of 4 that have wheezing and noisy breathing, but don't really have an obvious discernible mechanism. And then sort of the ones that we're used to seeing, that more persistent kind of phenotype, the kids that are already early onset, allergically sensitized, have evidence of eczema, have evidence of eosinophilia when you look at their blood. So they have a lot of eosinophils on their blood. And those are the kids that often were, and not that the other kids can't be severe, but are more typical severe asthmatic as they move through, is going to be that early onset atopic, kid with eczema and that classic sort of atopic march, right? But, in clinic, especially in the hospital, right? I mean, during the wintertime, it's gobs and gobs and gobs of kids that are wheezy and noisy, right? So most common symptom early in life. And some of these kids, they may not do it again. Sometimes I'll tell parents, especially if it's the first episode, like, look, over half of kids are going to have at least one isolated wheezing episode early in childhood. This does not mean that this is going to be for the rest of their life, and a smaller proportion of those are going to go on to have further episodes of wheezing. And so by far and away, I would say the most common reason when a mom comes in the clinic with their child, the most common thing that they say is, well, it all started when they went to daycare, and then they get their cold and then it just sets off this thing. And that's like by far and away the most commonly reported sort of, kind of inciting event. But once again, back to what we're calling wheezing, and also realizing not everything that wheezes is asthma, right? So by far and away, bronchiolitis is going to be the most common reason that we're going to meet kids in the hospital, especially during the winter, and they're going to be noisy. RSV is our most common viral reason for wheezing, and our most common viral reason for bronchiolitis, especially in our younger children. And so it's really responsible for a lot of hospitalizations and a lot of deaths and a lot of impact on our healthcare system. And whether or not that then ends up being asthma is, is something that is not totally clear, but, I think we understand more about. But one of the things is talking about reasons for wheezing. So the histology down there, so that's a bronchial lumen, a normal one, right? Nice, open, right? You can get air in and out, not any turbulent airflow. Right next to it, that's RSV, right? So it's full of mucus and denuded epithelial cells from the upper airway, insipated, just thick stuff that's causing significant airflow obstruction. So that's why they have labored breathing, especially in our younger infants. That's why they're in the hospital, they're on oxygen, and they're noisy. Sometimes I say they sound a bit like Darth Vader when you listen with their stethoscope. It's a little higher pitch, but it's this monophonic, just sort of constant sort of sound. And that's different than when you go listen to an asthmatic. The hard part is folded into all those kids with RSV, that's when you got to take a history and find out maybe they're a little bit older, maybe they're 18 months old and they're not 3 months old. And this is their fourth time that they've been in the hospital. And they had RSV last season, they've had rhinovirus, they've had multiple other viral insults, and they still sound like Darth Vader because they've got RSV again and they sound like that. But folded into them, they also have bronchospasm, they also have airway inflammation. So it's more complex. And sometimes that can even make it hard to assess whether or not albuterol helps them. And so the virus often matters, right? We've got these guidelines. How do we manage kids with virus and bronchiolitis in the hospital? And infamously, this, AAP says, do nothing. But it matters, right? I always tell the residents, take a history, talk to the families, find out if this is our first episode, find out if this is our third or fourth episode. And sometimes, and hopefully I'll make a case for it, which virus that the child has can make a difference, right? So we think a lot about RSV when we think about bronchiolitis, and that is early in life, right? The most common reason for to have bronchiolitis. But as we get older and as we get above a year of age, you start to see some of the other viruses, and specifically we start to see rhinovirus play a really big role in episodes of hospitalization for bronchiolitis. And these viruses impact our airway differently. I alluded to the fact, RSV tends to cause a lot of epithelial damage and destruction and sloughing of the epithelial cells, a lot of inflammatory response and obstruction due to mucus in the airways, whereas rhinovirus tends to be a bit more of a kind of a systemic inflammatory process within, or not systemic, but at least within the airways. It might trigger more of a Th2 type inflammatory response. And so when we get kids that are wheezing and having symptoms with rhinovirus, it means something a little bit more than our kids that wheeze with RSV. And so asthma and childhood wheezing, right, it tends to be the result of recurrent acute episodes. And like I said, over half of kids are going to have at least one episode, with the most common reason being viruses. But sometimes we'll also find bacteria as a reason for these wheezing episodes in these young kids, such as Haemophilus influenza, strep pneumonia, Moraxella, and mycoplasma. And it's hard, right, when you're sitting at the bedside to really think about how do we think about this child who's having these symptoms. And sometimes the normal child may be the hardest to diagnose out of all of it, because once again, they're there with symptoms, they're retracting, they're wheezing, the mom is worried, and so you're trying to make mom feel better, you're trying to help her kind of calm down, and/or dad. But then we're also trying to figure out whether or not there's more to this story, right? And so are there other diagnoses? Do they have could there be a foreign body? Could there be other infectious reasons? And then or is this child falling into this pattern where this has happened multiple times and it's really recurrent? And so we know when we look at kids with asthma at the age of 6, that these viruses, if you have these viruses early in life, right? So if in year 1, if you've wheezed with RSV, it's more likely that you're going to have, some diagnosis of asthma. But as you go on, right, you can see, the diagnosis of asthma at age 6 in patients that are having noisy and wheezing episodes with rhinovirus is much higher. And so the risk of having asthma or asthma-like symptoms at the age of 6 is much higher if you're wheezing with rhinovirus than if you're wheezing with RSV. And in this study, you can see that forest plot that's over to the right, that's sort of the risk. And if it's to the right, it favors the risk of asthma at age 6 for rhinovirus, and to the left, it's RSV. And you can see everything really is pretty solidly over there to the right. So the risk really of rhinovirus is a much higher risk of asthma than it is for RSV. Although we do see kids with wheezing episodes and sometimes recurrent wheezing with RSV, but it seems to be something that's that transient sort of phenomenon that they outgrow pretty early in life, right? So we know that they can have some chronic symptoms, but it's unclear whether or not it's the early RSV that's causing some of these symptoms, or whether it was something that was already, that the child was already predisposed. But it seems that even if we're able to prevent the RSV infection, it doesn't make as much of a difference long term as we would hope. And so really recurrent wheezing with RSV really seems to, kind of become less of a problem as they get older, as opposed to rhinovirus, like I said. So RSV, illness during the first 3 years of life can be associated with increased wheezing, but the risk with rhinovirus is much, much higher. Checking on how I'm doing. So rhinovirus, most detected virus early in life, especially, but in those older kids, especially that are over 12 months of age. And early rhinoviral infection during that first 3 years may increase the risk of asthma development by the age of 6 up to 40-fold. So really a much higher risk, and it impacts airway function. So you can see FEV1 kind of to the right, and patients that are wheezing with rhinovirus, and they look at age 6 or age 5, 6, 7, and 8, and you can see in the gold, those are patients that are wheezing with those rhinovirus illnesses, and their FEV1s are lower than the patients that were wheezing with RSV at those same ages. So rhinovirus does something different and more prolonged in the airway. And if we're talking about wheezing and viruses and impact on viruses, it's hard to not at least acknowledge the phenomenon that I think there's going to be a lot of area of research if we can go back and try to look at it. But so this is a breakdown of asthma exacerbations per month in the years leading up to the COVID pandemic. And then during that year when everyone was locked down, hiding in caves, and we weren't around anyone, and at least in the pediatric side, our emergency rooms were pretty empty and our children's hospitals were closed because we didn't have wheezing kids. We didn't have bronchiolitis, right? So that difference between the sort of salmon color or whatever you would call orange, is what it shows up there, is 2019, 2020, and then 2020, 2021. It's pretty striking. So when you take kids out of this stew of viruses, it's pretty amazing the difference that you see in terms of wheezing episodes. And so this is, I think, where it matters, is once again, going back to that concept of phenotype and endotype and mechanisms. But more importantly, when you're talking to a mom, right, you've got this worried mom because you've got you're seeing a kid in clinic and they've been in the hospital once or twice. So thinking back to those vignettes, this has been recurrent. Mom wants to know, is this does this really mean asthma, and how long? Is this something that's going to be lifelong? And so we're not, I tell families, I can't predict the future entirely. Otherwise I'd play the lottery and then they wouldn't see me in clinic. But we use things like the modified asthma predictive index to try to help sort of risk stratify. And I'll tell them really the negative predictive value of the asthma predictive index, which is a fun sentence to try to say quickly, but is really the power of it, right? So that these are kids that don't have these hallmarks, these either major or minor criteria. They don't have a parental history of asthma. They don't have evidence of pre-existing sort of atopic dermatitis. They don't have other evidence of allergic sensitization, then it's very likely, very, very likely that they're going to outgrow this as they get a little older. That's that block of kids Dr. Lucas talked about, where if you're taking history, dad will say, oh yeah, my mom said I had asthma when I was a kid, but I outgrew it, right? That's that block kind of kids usually, versus when we've got more of these other risk factors. The child had some eczema. Mom still carries an inhaler with her because she has some asthma when she runs and does some things, right? There's been some question of allergy. They've had maybe some wheezing or difficulty even when they're not sick. Those are all red flags for more persistent asthma, more persistent symptoms as they get older, right? And so that is helpful. And then of course I try to, not make the mom super worried and say now, if they have a positive modified asthma predictive index like that, now things are baked in stone, but trying to help at least mom feel a little bit better about where we think this is going. And especially as you look, that allergic sensitization early in life is a strong indicator really for whether this is going to persist into childhood. You can see in the blue, these are patients that are not allergically sensitized early in life. And you really see that precipitously fall off as we get into around age 6, age 7, versus that persistence in that atopic block, right? But it's still after 2 decades, right after, Tucson and following all these cohorts over time, we still have unanswered questions really exactly about how to appropriately manage preschool age children with wheezing. We're still not 100% accurate with predicting what we think is going to happen as they move into the future. And we're still trying to figure out what are appropriate treatment sort of paradigms. Who do you choose to use inhaled corticosteroids with? Who do you just stick albuterol with? Who do you think about other things? And we really need more studies. And I'm going to go into, at the end of the talk, some kind of exciting things maybe where we kind of start to get at some of that, right? So we've got this course of these, preschool wheezers, and what are some predictors for remission, right? So we know male sex is more of a predictor of remission. We know, of course, like I said before, lack of allergic comorbidity and less airway obstruction versus sort of predictors of persistence, right? So more, if they're female, there's more airway obstruction, they have more significant symptoms, and then they have that early allergic sensitization. But about 27% of the preschool wheezers, so that all of those kids that, on that Oprah Winfrey slide, right, that were having all those symptoms, only about 27% of those are going to go on to have persistent symptoms, and about 50% are going to have remission as they move into adulthood. And then even in the adolescents, only about 3 to 5 are going to continue to wheeze and have persistence. And so it's that block that we're really trying to figure out what are those indicators, right? As we look at biomarkers, right? Looking at eosinophils, looking at pheno, looking at allergic sensitization, looking at maybe genetic predisposition or other aspects. And so that kind of segues into this idea of where does it start in asthma development. And Dr. Lucas showed, some really great slides talking about the kind of multifactorial impact, right? Development of childhood asthma can be impacted by environmental exposures like tobacco, daycare, exposure to farms and farm animals. And we'll talk a little bit about some of that. Of course, viral infections like I just outlined, and then whether or not they're allergically sensitized. And then there's these epigenetic mechanisms, right? So the epigenetic, I think, mechanisms are really interesting because this is how the environment can come in and change expression of certain genes, right? So we think of our genetic code as sort of being baked in as being kind of who we are. But our expression of certain genes and how those then impact clinical symptoms can change based on environmental exposures, right? So the word epigenetic really means around or above. So the genes themselves don't change. It's just how strongly we may express or how strongly those genes may drive disease changes based on exposure. And some of there's been some really cool work. Actually, Dr. Eric Forno did some really cool stuff looking at methylation in the nasal mucosa of certain patients in Puerto Rico after hurricane exposure. So we think a lot about, mold, or we think a lot about, other disaster type exposures, but even looking at how does the stress and strain of being exposed to gun violence or being exposed to a hurricane can impact methylation of certain asthma genes and impact asthma severity, just based on those types of exposures. So it's a pretty interesting sort of phenomenon. So like we said, asthma is multifaceted in the susceptibility, right? Both genetic and environmental. So we've got sort of that genetic risk that we have, but then there's going to be these environmental exposures, both pre and post birth, that can impact that clinical window, that critical window in terms of asthma, right? So whether or not prenatally something that happens in the womb may skew one of the may skew the fetus more towards that allergic or Th2 type phenotype. When I was showing that sort of relay race, we talk about type 2 high or sort of that's the more typical kind of allergic type of asthma with sort of these typical cytokines that then results in a lot of inflammation like IL-4, IL-5, and IL-13. But it can be due to intrauterine environments. It can be due to imbalance between that skewing between that Th1 versus Th2, and that can be whether it's maternal infection, it can be underlying genetic factors, it can be post sort of viral exposures. But a lot of these things there's a lot of different reasons and etiologies for some of these things to occur, right? And so especially the more long-term asthmatics, right? 2/3 of patients with asthma are going to have an allergic component as they get older, and only about 1/3 may have that non-allergic. So really the largest population of the more significant asthmatics are going to be that allergic asthma phenotype. And that difference in atopic status and age of onset may suggest that there's a different cause of asthma in those patients, right? So as we try to move past symptoms and try to understand these mechanisms, that helps us understand treatment, but hopefully also helps us understand prevention, right? So it's this sort of balance between risk factors both in the womb as well as risk factors early in life, and then risk factors as we get older. And so some examples of kind of prenatal risk factors for asthma development. So some children's, like I said early in that with Dr. Fernandez, right? So some children with recurrent wheezing might have pre-existing abnormal lung function, may have abnormal airways hyperreactivity, may have some impact in development of branching morphogenesis of their airways. And so they're sort of set to have at least noisy breathing and labored breathing with virus early in life from a structural standpoint. There's been studies that have linked, supplementation with some of the fatty acids to reduce risk of asthma and lower recurrent lower respiratory tract infections by as much as 30% in the offspring. And then high dose vitamin D supplementation during pregnancy has been suggested to decrease asthma risk, by up to 25%. And to make it, complicated, actually, I heard one of the guys, so VDART was one of the big vitamin D trials looking at giving vitamin D supplementation to pregnant, mothers. And they, when you hear the guy kind of present the data, he said, we had to pick a dose, we had to pick a time, we had to start the trial. And then infamously, as they went through the trial, and they really felt pretty confident they were going to see an outcome, and it ended up not meeting statistical significance, but very, very, very close. In retrospect, as they've looked at other studies and that they've looked at some sub-data analyses, they realized that they probably didn't pick the right time when they gave the vitamin D, and they probably didn't pick the right dose. So, it's a complicated process, especially when we're talking about some of the prenatal interactions. Of course, from a genetic standpoint, heritability of asthma can affect, or at least the risk of asthma by up to 60%. There's been large genome-wide association studies. These GWAS studies have identified multiple, sort of genetic loci for different reasons for increased either allergic risk or asthma risk or airway hyperreactivity. We know, like Dr. Lucas said, maternal ATP is a stronger risk than paternal kind of history of ATP. And when we look at children born to mothers with asthma, there's at least a threefold increased risk, right? So that maternal family history is stronger. Interestingly, right, so the most well-described gene associated with asthma is this 17q12 to Q21, right? Most replicated genetic loci for childhood onset asthma. But interestingly, this has nothing to do with allergy or ATP, right? So this seems to be more of a risk for that preschool wheeze kind of population and doesn't seem to be as much of a risk for later onset wheeze, right? This is strongly associated with early life viral respiratory infections and then wheezing with viral illness, but not lifelong asthma risk or kind of allergic driven asthma risk. And so this is not meant to be read, as you can see, but this is just a list of some of the genes that have been identified. Oh man, sorry, I looked at the 15-minute slide. So we know, of course, our premature infants. So that picture up there, you can kind of see sort of airways of a premature infant. And we know that the effects of prematurity really impacting lung development, branching morphogenesis, and that's going to place us at increased risk. And then the microbiome, which I think is really, really important. We know that the microbiome is complex. It can involve the microbiome in our airway, the microbiome in our GI tract, and the interaction between all of these these different microbes and what that impact they may have on our developing immune system, and that skewing from Th1 to Th2, both in the GI tract as well as the respiratory tract. And it develops very early in life. And this is why we see the increased risk of asthma in kids that are born via C-section versus vaginal delivery. That's why we can see sometimes the increased risk of asthma in early use of antibiotics versus later use of antibiotics, and early use of H2 blockers and acid suppression because we're changing the pH of the GI tract. And so we know that early development and that early microbiome is really important. And one of the, that was sort of the beginning of this idea of the hygiene hypothesis, right? This early observation that we saw more asthma in patients in those more rural populations than in the urban populations. And I'm zooming through just because I'm going to get to some where we can talk a little bit. There we go. So we know that being on a farm seems to be protective. These were two studies sort of looking at sort of populations of patients that are born on farms versus not on farms, and that farming environment and or ownership of pets could reduce the risk of asthma, allergy, and ATP. And one of the, I think the more striking examples is when we look at Amish versus Hutterite population. So Amish, of course, very primitive farming method. They pretty much live, with their animals. They're in with everything, and they really don't have the sort of modern farming techniques that might be considered protective from that environment that they're farming in. Versus the Hutterite, which is genetically very similar to the Amish population, but they sort of personally believe in more modern farming methods, and so they're still there, but they use more sort of clean environments, if you will. And we saw the incidence of asthma in the Amish population being up only about 5%, but in sort of a genetically similar population being as high as 21.3%, right? So this pretty significant change. And it seems to be difference in both the endotoxin present that's in the environment. So it's it's that exposure to the animals, but then that exposure carries into the home environment. So the endotoxins that are present in the dust that are present in the environment in the home are different between the Amish farm environment versus the Hutterite. And then even when they look at the microbiome, that the bacterial richness, that bacterial diversity is different depending on that environment that they grew up in. And so the idea is that it's that diversity of this population of bacteria that are responsible for that early education of our immune system, that early education that skews us maybe to a more allergic framework, right? And so environmental and personal microbiota, especially in the gut, can influence that trajectory towards asthma, right? So and so that, of course, looks at, asthma prevention. Are there ways that we can help support that gut microbiota to help protect against asthma development? The goal would be disease prevention based on either those, kind of microbial interventions, but it's challenging. We can't really put everyone in these cow sheds or there's something sort of magical. So we're still figuring out what that magic is in terms of the environment, right? So current efforts, to decrease the asthma burden using products derived from multiple microbial bacterial strains to help with our immune maturation. And so two examples are OM85, which is a bacterial lysate, and MB130, which is a whole cell heat inactivated bacterial mixture. And one of the other, let me do this one. So this I think is one of the more kind of exciting. So this is OM85. It's a bacterial lysate that's pretty widely available over in Europe. We don't really have it as available here in the United States, and they routinely will use it to help modify the severity and trajectory of these viral-associated wheezing episodes over there. And so the idea is, well, what if we're able to modify, and we take a high-risk population of children with a family history, with maybe some early on evidence of eczema, and we provide them exposure to this bacterial lysate, are we able to help support a more normal or a more favorable microbiome, we'll say normal, to help prevent the onset of asthma in a high-risk population? And so there's this study, Orbex, and it's getting ready. I think some of the results should hopefully come out I think next year. Those are some of the study locations, right? So, they're all big places here in the United States, but the idea is that they're taking, it's a 5-year trial, but during those first 3 years, they're going to give them that OM85. I think it's 3 days a week for those first 2 years, and then follow them longitudinally. And so I think it's going to be really exciting to kind of see what impact that has, once again, as we look at this huge proportion of kids, what impact does supporting a more normal microbiome have on that development of asthma. There's another trial coming that hopefully should be resulting pretty soon called PARC, where they looked at high-risk populations and gave them Xolair. So tried to really inhibit IgE very early in life and to see whether or not that affects asthma development. So, the holy grail, I think, for those of us that take care of kids with asthma is asthma prevention, or at least asthma modification as we think about asthma development. Beyond that, of course, we've got other phenotypes. The obesity-related asthma is multifactorial and complex. And what I would say is, if you just Google, and I checked actually while I was sitting there, if you just Google Asthma Coalition YouTube, or the Florida Asthma Coalition YouTube, there's the recordings of all the talks from all the different symposia are there. And Eric Forno gave a really good, at our first sort of virtual summit, gave a really great sort of high arching kind of, but still deep dive into asthma, sort of obesity related asthma. And so I would encourage you to go listen to him, because he did it's been an area of research for him for a very long time. And it does it much better justice than this slide. Of course, we have, a lot of adolescents that show up with exercise-induced bronchospasm. I think it's important to realize that there's a time course to this, right? So it begins usually several minutes in, peaks around 10 to 15 minutes. So it's not something that happens right away. And that's important because, as we talk about asthma, and as you think back to those cases, that's where we start to get into some things that may mimic or masquerade as asthma, right? So one of the things I'd reference tracheomalacia, right? So here's a picture of a normal trachea. And then here you can see pictures of pretty significant tracheomalacia where that posterior wall is really coming in, and or the anterior part of the kind of cartilage itself may be very soft, but it causes airflow obstruction, and it's an anatomical reason. Here is our pictures of somebody with vocal cord dysfunction. So to the left, right, you've got normal vocal cord movement. Normally when we breathe in, our vocal cords should be wide open, and they should not cause obstruction. But in someone that has kind of what we call paradoxical vocal fold movement or vocal cord dysfunction or exercise-induced laryngospasm. We change what we call it, every 5 years to make people think we're smart, but we'll see changes in that vocal cord position that can cause obstruction. And that can, sorry, I keep rotating. So that kind of projects, and sometimes it's more than just the vocal cords, right? So the vocal cords can come in, but you can also have supraglottic obstruction where the arytenoids go in, or even the epiglottis kind of causes a source of obstruction. So you can have supraglottic collapse, or you can have vocal fold abduction kind of coming together, causing obstruction. And so you can see there's a typical flow volume loop. Really no one's flow volume looks like what it's supposed to look like in a textbook, but there's the example, right? That high increase in flow with that gradual sort of decline down. And then you take the breath in and it should look like the bottom of an egg. And then here you can see examples of flattening, which would lead you to think about VCD. Although when you talk to VCD experts, they really say they rarely see that. Occasionally I'll see it in clinic, but I think it's because I've already made up my mind that the patient has vocal cord dysfunction based on their history or based on their symptoms. And so then now I see the flattening of the inspiratory limb because it's wishful thinking. And so I think, as we talk about, and as I sort of went pretty quickly through different risk factors, as we think about asthma and as it changes through childhood, you can see it's this overlapping kind of Venn diagram, right? We've got viruses, we've got different treatments and exposures, whether it's antibiotic exposure, whether it's antacids, whether it's, different other things that may impact the developing airway and or the microbiome. We've got environmental exposures like we talked about with the farm environment. We've got other pre-existing conditions in terms of airway development and airway size and caliber, and then genetics and how genetics can change with exposure to your environment over time. And then, like I said, how that microbiome and all these things overlap and are all just sort of identified risk factors for asthma as we move through childhood, and then realizing that as those risk factors change, so may our asthma symptoms change. And so circling back, thinking of these patients, right? So the 3-month-old male recently admitted with RSV, right? So this was the first episode. We're coughing, we're wheezing, but we have no other medical kind of conditions. And so this sounds like more typical for just isolated bronchiolitis. And at this stage, we can't really make much of a comment about long-term risk other than the fact that they had RSV and they were young. So they may be at increased risk for recurrent viral illness, but not so much in terms of asthma as a diagnosis versus the 14-month-old male where this has happened multiple times. It seems like steroids help. It seems like albuterol helps as best as you can tell. Hopefully you objectively are at bedside listening to them before and after the delivery of that albuterol. And so this is someone who you would at least predict would be more at risk to have ongoing recurrent wheeze and at least into sort of school age years, because we also have a family history of asthma, right? And then this is the sort of typical 12-year-old female. We've had eczema. We have lots of symptoms. We have lots of risk factors. We have allergies. We take allergy medicine seasonally. So that would, suggest that there's, some environmental allergy, at least seasonal allergy. But of course she's not controlled because like usual, the mom hasn't been explained the role for inhaled corticosteroids and control of inflammation. And so that's why she keeps having problems. And then the last case is that teenager, the volleyball player, there's a lot of stress on her and people can hear the wheezing. And so she's making a noise. But really in asthma, if you're not going to hear the asthma wheeze if you're 4 foot away from them. If you're hearing that noise, that's central or that's usually the larynx, right? So they're hearing episodes of inspiratory stridor that are kind of freaking out her friends. And so this is the classic vocal cord dysfunction. And sometimes they walk in the clinic like this, but this is I tried to make it as obvious as I could. But so, one of those more mimickers and not really true asthma. And that's it. 1046.
When you're talking the asthma group, when your kids are like elementary school age,
yeah.
RSV.
Yeah.
What considering that it might be beyond asthma that's affecting them, perhaps an immune problem or something like that?
That's a little bit harder, right? So, and Dr. Ramirez, as an immunologist, can you probably even speak better to that? When in our kids, when you cross the line of getting sick frequently and when you're getting sick too much is a tough line, right? I mean, all the moms will come in and say, my kid's sick all the time. My kid's sick too much, right? Too frequently. And often though, especially in our kids where it is sort of that, where it's viral associated wheezing episodes, because until you get things under control, often those episodes are longer in duration. They're lasting weeks in terms of some degree of symptoms, it becomes this blur because it can be normal to have, 6 viral illnesses that, in a given year, and sometimes they can kind of cohort in a certain time frame. And so until you get things, if there is an inflammatory piece, if they're going to respond to inhaled corticosteroids, they're going to seem like they're sick all the time. And so often, that is more common than a primary immunodeficiency. So I usually, at least I will approach it as sort of assuming that there's some degree of airway inflammation and asthma, because usually I can figure that out in a shorter time frame, unless there's other markers, right? We've got chronic diarrhea, we've got poor weight gain, we've got focal infections, we've got obvious pneumonias, we've got skin infections, other markers of a more significant bacterial infection. But when it's the more typical, where it's just they're in daycare and they're getting virus after virus after virus, it's not as much of a kind of a clear line. But the number of infections and then what has been done, kind of leading up to it in terms of some attempt to control or prevent or modify their response to those infections. Oh, yeah. So is anyone researching salt therapy? It has been very effective for our clients, and the salt suite for 10 years liquefies mucus and decreases inflammation. So I would say, that was the question. So not that I'm aware of it in terms of any objective long-term longitudinal studies. I would say, of course, in our bronchiolytics, the one therapy that's been moderately, shown to have some effect, depending on your outcome measure in bronchiolitis, is hypertonic saline, right? So we'll routinely nebulize 3% hypertonic saline to help hydrate the secretions, to help make our cough more effective. In order to cough, you've got to be able to get air around the cough, and the cough has to be at least not super tacky and sticky and adherent to the wall. So creating a less viscous mucus might be more effective. Whether or not, in long term, of course, like anything, you worry about environmental exposure, you worry about the cleanliness, just not sure in terms of the actual location itself. And so I think it's hard to make a blanket recommendation when I'm sure there's some variability in terms of the maintenance of some of those locations. So that's about as probably close as I'm going to get to an answer. Awesome. Thank you.